Hello. So the first question that I seen in the text that we were doing our readings is from the DSM-5, Clinical Social Work, Mental Disorder, and Psychological Justice Goals of the Clinical Article, meaning that I have found that the most skillful person is the social worker to diagnose and treat depression, meaning that they usually take cases that are mild or moderate cases, which are involvement in social and interpersonal triggers, and in maintaining causes with the impact of brain disease ideology has been powerful, and it's very practical perspective, I would say, with the ethical issues of the misdiagnosis. This situation presents a very more presents a dilemma, even though we as social workers can do so much more. As for number two, I discussed that the common error in the ethical and legal issues is the misdiagnosis. A lot of people say that we use a misdiagnosis, even though plenty of people have critiqued it as fraud. We tend to use it as a more, as for the social work clinician, they tend to deal with more and more having more legal right authority to diagnose individuals who have suffered from these various mental disorders, and at the same time, which are very required to do so, using a system which may feel to be incompatible with the principles and values of the social work profession. Excuse me. As for number three, I discussed the basic steps of which is we gather the information and the basis from the clients. We normalizing the problems, which could be approached giving a more positive feedback view than with the pathological one, I guess, from the clients, meaning that they'll be regarded as normal than ill clients. As for the third step with watchful waiting, which is a watch and wait approach, wait and see approach. I apologize. That is needed for, but as for clinicians, it has been difficult to not pull the trigger on the diagnosis and treatment. And as for step four, we do the minimal interventions, which is doing interventions minimally with the clients and whatnot. As for number five, we do brief counseling, which has been beneficial to many clients. It's been very effective. It helped with a more positive. It is a more positive talk approach, making the clients feel that they can achieve their goals than what it seems like. As for the last one, we will be talking about definitive diagnosis and treatment, which is stated that the problems, there will be more intensive therapy and secondary care, although this process has alleviated the diagnosis inflammation process. I think it separates the patients that will be benefited from the psychiatric diagnosis, who will be fine on their own by not risking the undertreatment. Number four is name one positive and negative change. I would say one positive, negative change is for me with the DSM-5. I believe is it goes into detail. It even though it's layered into three different sections. Whereas the negative, a lot of people do not like how this book is in depth. I did see one diagnosis of the neurocognitive disorder, and it just went in depth about what it's like, what I've explained. And then the last question is, what are the concerns with the dimension basis, and in your opinion, which system makes more sense to you as a clinician? Well, the concerns I've seen with this the dimension system, which I found in the DSM-5, an overview of changes and controversies. It does have an alternative the DSM-5 has an alternative PD systems that has reached sources of the issues that have concerned the DSM-5 archetypes, such as too much use of categories and too much accountability. As the system has been based on each personality disorders consists of extreme personality traits and etc. I would say altogether, in my opinion, that this system, and as a clinician, I believe that the DSM-5 is helpful, but it also has its little tweaks as well. So thank you for watching my video.